Hi everyone, this is Kristen. The case study I chose is a multidisciplinary healthcare team disagrees with keeping the patient a full code. So in this case study, the patient is an 84-year-old gentleman named George. George has been admitted to the ICU for respiratory failure and multiple life-threatening comorbidities after having a severe case of COVID-19. He is currently on life-sustaining interventions, including dialysis and ventilation support. Despite several weeks of excellent intensive care and aggressive measures from the ICU team, George's situation continues to decline. Members of the ICU team and the palliative care consultant believe George's prognosis is poor and death is imminent. George has been unable to provide any verbal or nonverbal responses since his admission, and he has never completed any advance directives. His wife and daughter insist on continuing his full code status. Palliative care has met with the family and discussed the option of comfort measures. The family has stated that if the ventilator support is no longer working for George, at that point they would be willing to move forward with extubation and allow for a natural passing. Until then, even if his heart stops, they want full code status, including paddles, shocks, compressions, and, quote, whatever else it takes to give him a fighting chance. There is moral distress amongst the ICU team. The team feels that a full code on this frail 84-year-old gentleman would be torture. During a team huddle, the palliative care consultant states, "We need to help this family do the right thing and agree to transition this poor man to comfort measures only. Continued ventilation, dialysis, the whole 9 yards, and especially CPR is all futile. What we're doing is non-beneficial and harmful to this guy." The pulmonologist, Dr. Jacoby, says she understands and agrees that the prognosis is poor. However, she says, I cannot in good faith say to this family that the vent is not working or non-beneficial, at least in the sense that it surely is keeping George alive longer, and that seems to matter to this family. During the team huddle, the palliative care physician receives a text message from George's daughter that reads, "Mom and I are getting confused because we keep hearing different messages from doctors here. We want to do what's right for Dad, but it's just so hard to know what's really going on." In this unfortunate situation, the elderly patient is unable to speak for himself. By proxy, George's wife is his decision maker. In this case, I'm not sure I have a side to take. Dishonesty is not ethically responsible. However, keeping the patient alive longer because it matters to the family is also not ethically responsible. While I agree George's prognosis is poor and keeping him full code is not beneficial, our job is not to make that choice for the patient, but to fully educate his family so that they can make an informed decision. When discussing with the family, we should focus on the rights lens. An 18th century philosopher, Immanuel Kant, is one of the most influential interpretations on moral rights. Kant taught that each person has a worth and a dignity that must be respected. This is where the statement, "Humanity must always be treated as an end, not merely as a means," comes from. To treat someone as a means is to use a person to advance one's own interest. In this case, the interest of George's family to keep him alive. But to what end? George has the right to be treated as an end in and of himself and not as a means. Unfortunately, I have been in this situation in my career several times, and I have learned from wise providers and palliative care nurse practitioners. The best thing to do in this situation is to be brutally honest with George's family. Although difficult to hear, this family needs to hear what will happen during a code. They also need to hear that even if he does make it to a long-term care facility, the likelihood of him ever getting out of bed is low. His quality of life will never be the same after this event. They have to think about whether their loved one, who they say is a veteran and a fighter who would want he would want to live that life. They have to understand and respect his dignity. I would need to know the ventilator settings and whether an EEG had been done before I speak with the family. But from an ICU From the ICU team's response, I would assume that the vent is at a PEEP of 20 or close to max. If an EEG was done, it probably showed no activity. These two facts are very important when speaking with the family, and it is imperative that they understand what those mean. If after sedation was decreased and the EEG showed a flat or straight line, we explain to the family that this means that all brain function has stopped. Ventilator support should also be explained. Although, yes, the ventilator is keeping him alive right now, if we were to remove it, George would likely pass peacefully. If we were to code him in his frail condition, we would certainly break his ribs, which is very painful and causes damage and other complications as well. Even healthy, strong individuals can have broken ribs after adequate compressions. No member of the team should have to be dishonest in order to push the family to the right decision. To treat a person as an end is to respect that person's dignity by allowing each the freedom to choose for himself. I believe that if a well-trained palliative care physician and intensive care physician or pulmonologist were able to respectably and honestly convey George's status and prognosis, the family would likely make the decision to extubate and allow for a peaceful passing. Of course, this is not always the case, and there are times we may run into unrealistic family members. When all else has been attempted, the ethics committee should be able to assist in making an ethical choice. Thank you.